So much, everyone. So to any of you who might just be joining this second session, I wanted to say hello and thank you all for joining at the 2022 Leap into Advocacy Virtual Summit. My name is Sheyenne Walmsley, and I am a genetic counselor and project manager for the Genomes to People Research Program, which is based at Brigham Women's Hospital in Boston, Massachusetts. And if I can summarize G2P, it's really that we conduct research that explores what I like to refer to as our three tenets, which is the medical, behavioral, and economic impacts that the use of genomic information has on medicine. And so through this work, I was given the opportunity to meet one of our lovely organizers, Miss Sarita Edwards, and also is the reason I had this opportunity to speak with you all today. So I'm very excited to be here. And so the title of our second session for today is Using Culturally Appropriate Resources to Influence Health Equity and Access. But before I introduce you to our panel of speakers for today's session, I really just wanted to give you a quick introduction to how my personal career in genetics relates to health equity and access. So I'm just going to share a few quick slides. Great. And hopefully you all can see that. Please give me a thumbs up if you can. So with the popularity of direct-to-consumer testing, such as 23andMe, and also this surge of interest I think we've been seeing in society at large regarding our ancestry, I really wanted to start by talking about genetic ancestry and race in genomics. As many of you may already know, race is actually a construct that's influenced by social, political, and economic factors. And in many studies, race is typically self-identified. And so what many people might not actually realize is that genetic ancestry does not determine our race and ethnicity. It's actually loosely correlated which can be estimated through genetic data and is really more so representative of historical geography. And so in continuing with this topic of genetic the idea of race and ancestry, I also wanted to highlight some of the disparities that we see in genomic research and databases. So NOMAD referenced here is actually a resource that was developed by an international coalition of investigators to try and aggregate and kind of harmonize all of the data that we've collected from large-scale sequencing studies. And it may surprise you, or maybe not, that actually less than 10% of sequences are representative of individuals with African ancestry. And in similar fashion, we also see that in genome-wide associated studies, or studies that are really, their purpose is to help scientists identify genes that are associated with different types of diseases, are also mostly of European ancestry. So on this slide quoted at 78%. And so this lack of diversity we have seen in our own genetic studies. And so the project I'm referencing today is what we, as a pilot study that we refer back to as the Baby-Seq-1 study. And so this was a study that used genome sequencing in newborns, about 159 babies located in Boston. And we did find that about 11% of babies actually had a significant health-related finding. And one of our other findings was that there was actually no evidence to suggest that families receiving this information were upset by it, or that it significantly increased their healthcare costs. However, again, as I mentioned, this lack of diversity, almost all parents who enrolled were non-Hispanic white. And of course, there's a lot of factors that go into this. We only enrolled in Boston. This was also a project that at the time was very controversial, and also some of that controversy lingers today about whether or not we should be doing this sort of expansive testing on newborns. But if we look at the bigger picture, we also know that one, although not the major, not the cause, but one of the major causes of this lack of diversity that we see in genomics results from historical injustices that have led to mistrust in research among minorities and has greatened some of these health disparities and inequities that we see today. And so we're actually hoping to, well, we are doing a second iteration of the BabySeq study, in which we hope to enroll a more diverse cohort of families, including those who identify as Black or African American or Hispanic or Latino. And one of the very influential pieces of our study design and how we plan to do this is that we've convened a stakeholder board of 10 members with community representation from the 3 original sites that we plan to recruit from. Since then, we've actually expanded to 2 additional sites, including Philadelphia and Detroit, which is not pictured here currently. But pretty much we met with our stakeholder board on a quarterly basis via Zoom. We do compensate them $1,000 for their time per year that they are involved in the study. And just in this first year of feedback alone, they have been very influential on many aspects of our study design, which I have summarized on my final slide. And this includes inclusion criteria, informed consent, sample collection, and cascade testing. So originally, we were going to require that 2 parents be required in order to participate in the study. But it was our stakeholder board who really emphasized the spectrum of family structures that and requiring this 2 parents to participate could really be exclusive to many families, especially with the group that we're trying to recruit. And so we actually expanded our criteria to include more babies in family structures by only requiring 1 parent or legal guardian. And almost any baby. We also had our stakeholder board revise our informed consent form, which is probably the most important document within a study, getting a study started. And this has actually been very influential to the Institutional Review Board, which is an administrative body that is responsible for protecting the rights and welfare of human research subjects. So they actually hope to use our consent form as a template for, to have more accessible language for other studies moving forward. So we were very excited to hear that. And then very quickly, to summarize our last 2 points, we did also adjust our sample to a heel stick as it was less invasive. For our infants. And also we removed requirements to collect samples of our parents and also the control group, meaning babies who would be randomly assigned to the group that wouldn't receive genome sequencing in this study. We felt that if we maintained these requirements, that it would actually potentially exacerbate some of the mistrust that we know we see today. And of course, genetic testing is a family affair. We share many of our genes and DNA with our family members. And so with input from the stakeholder board, we also updated our protocol to offer optional testing for any parents and siblings of infants who are identified to have a health risk of some kind. And so thank you for allowing me some time to review some of the work I've been involved in. And of course, we have not cracked the code to resolve any and all health disparities. But this work, it's been amazing to work with the stakeholder board, and it's definitely inspires me as far as the further work we could do to continue to combat health disparities and inequities. And hopefully by the end of this session, you guys will also be inspired if you're not already. So without any further ado, I would love to introduce our next presenter, Dr. Shruti Mitkus, who is going to present on some of her work and experiences as the Director of Genetic Education and Navigation for Global Genes.
Thank you, Cheyenne. Hello, everyone. Very nice to meet you. Um, Quick background about myself, like Cheyenne mentioned. My name is Shruti Mitkus. Um, I am not a patient, but I'm a patient advocate. My background is in human genetics. So I got my doctorate in human genetics and have since then worked in a bunch of fields related to rare disease. Um, I am now the Director of Genetic Education and Navigation at Global Genes. Um, some of you might know of Global Genes, but we are a patient advocacy organization, and our focus is on patients that live with rare disease. And so I'm going to share with you um, my presentation that is going to talk a little bit about using culturally appropriate resources and the impact of um, culture on healthcare. And before I start, I just want to, well, let me first share my screen with you. All right. Hopefully everyone can see my slides. I did want to start off by the disclaimer that I do not claim to be an expert in um, culturally appropriate talk in healthcare. I am learning, just like I'm sure a lot of us are. I'm learning a lot from my colleagues that work at Global Genes, patients that I've spoken to, had the pleasure of meeting Sarita at one of our meetings in Philadelphia and learned a tremendous amount about the patient experience and how culturally appropriate resources can impact healthcare. And so please take my slides with that little disclaimer in mind. So the title of my talk is Using Culturally Appropriate Resources to Influence Health Equity and Access. So I wanted to start off very quickly by just highlighting culture as we define it. It encompasses so much more than we might think of. So it encompasses customary beliefs, any social forms and norms that we have in how we behave, and any material traits that can either be racial, they can be religious, they can be geographical, depending on where you come from, either in a country or on the planet. And it can also be social groups that we subscribe to and belong to. And I just wanted to put this slide up here so we can get a sense of and appreciate how all-encompassing culture can be in one's outlook, not just in our day-to-day outlook on life, but also when we access healthcare. So it also includes personal identification, how we perceive ourselves and what cultural group we belong to, language, the way we think about things and how we communicate those things within our group and outside of our group. And as I mentioned before, it is a characteristic feature of our everyday existence. And so a divorce of culture from healthcare or really any other aspect of our life is not realistic and it cannot be trivialized at all. Culture, as I said, is all encompassing. I put down here a list of the things that one generally thinks of when one thinks of one's culture. But again, this list is not exhaustive at all. Some of the key things that might impact a number of things, but particularly healthcare, could be a person's age, where they come from, how long they've lived in the country that they've lived in, their education levels, what language they speak, what their sexual orientation is, their political beliefs and how they see those beliefs being enacted out day to day. And of course, the racial and ethnic group that a person belongs to. And like Sheyenne mentioned, not just belongs to in terms of how they look or what their genetic makeup is, but what they really identify themselves in and the group of people that share similar beliefs to them is what we refer to as their ethnic group as well. And then socioeconomic status, we cannot divorce talks of culture with understanding the socioeconomic background that a person comes from and how that influences how they view healthcare, how they access healthcare, and how their their beliefs about whether they can access that healthcare, how that changes depending on their socioeconomic status. So I just wanted to give a quick flavor of all the different aspects of culture and things to keep in mind when we talk about developing culturally appropriate material. So the role of culture in healthcare, as I touched upon briefly, healthcare is not something that is not impacted by a person's belief in their cultures. It's influenced not just with our regular day-to-day beliefs in how we live and what kind of language we speak and what kind of food we enjoy eating, but also our beliefs surrounding health in general and wellness and how we see illness and disease. Do we see it as an intrinsic problem within oneself, or do we identify it as something that is a curse from a god that we might have displeased, or do we identify well-being as something that is a community affair? So our beliefs in how we look at healthcare and health information are largely driven by our cultural context and where we come from. So cultural respect of that has to have an important say, and we've done studies where we know this has a positive effect on patient care. So delivering services that are respectful of a person's background and are responsive to their health beliefs, their practices, and their cultural and linguistic needs is extremely important if we want that service to be of effect in the population that we're targeting. Cultural respect can also improve access to high quality healthcare. So the more culturally appropriate the healthcare information is, the more accessible it is to the community that one is trying to impact. We can enable organizations to function effectively, to understand the needs of the individuals that are accessing this information. And of course, it is critical to reduce these health disparities and access to unbiased quality care. So unless we have a concerted effort of developing educational material and healthcare information and clinical trials, unless we make a concerted effort to develop those using the cultural perspective of the audience that we're trying to target, the effectiveness of our material is definitely going to suffer. Cultural competence is the capability to acknowledge and respect one's individual identity, ethnicity, language, and cultural beliefs. And when I say not just acknowledge, but respecting that this is a driving force in decision making in this person, and that's something that needs to be respected. And I'll give subsequent examples of what I mean by respecting a person's culture when making decisions in healthcare. So I wanted to highlight here really quickly a couple of examples that I came across where cultural barriers limit access to healthcare. And I'm highlighting here the experience of immigrants. So immigrant patient-provider interactions suffer because there is a disconnect, not only with regard to language, but also to culture. And these are direct quotes from this news article on this paper that was published. And I've provided the source here. Everyone is welcome to read it for themselves. But essentially, culture and language differences, lower socioeconomic status, and lack of knowledge seem to be key barriers in accessing healthcare within the immigrant population. And so communicating with the healthcare providers, understanding the health directive that the provider is directing the patients to, that was found to be a barrier if the language that was spoken was not the same as a patient that was accessing the care. And here it says they are hesitant to seek care. I think the authors are saying that immigrant populations in general are hesitant to seek care from Western physicians due to the experience of stereotyping by physicians. And this touches upon an important point about maybe conscious and unconscious biases that physicians may have just by looking at someone or seeing that they don't speak the same language as them, there might be some perceived biases. And the only way that one can tackle that moving forward is through education and creating resources for physicians to familiarize themselves about these biases that they may or may not have, and then address the healthcare system through that means. So lack of cultural awareness by physicians affects communication. And they are more directed with immigrant patients and deliberately withhold information based on the belief that the immigrant patients will have limited understanding. And this is what I was speaking to when I said unconscious biases. A lot of us tend to think that if someone doesn't speak the same language as us, they are somehow diminished in their capacity to understand directives as a physician or as a healthcare person. And that is certainly a bias that we have to address, because judging someone on their linguistic style and the language they choose to speak in and how that impacts their healthcare should not be one of the things that patients have to deal with. Another study or another article that I read recently, and I wanted to highlight here just to talk a little bit about the inequities that certain populations that are underserved, like in this case, Black women, the kind of inequities that they face. So this was a poster that was presented at the American Society of Clinical Oncology meeting this past spring. And it talked about how the majority of Black women with metastatic breast cancer don't get enrolled into research clinical trials. Only 40% of Black respondents said that they were even offered a trial. And the author of this poster made the comment that nobody even talks to us about clinical trials. And this highlights the need to understand what the bias is or what the barriers are in accessing care, particularly when it comes to race or socioeconomic standing. The fact that physicians or research centers are not even offering clinical trials to patients, perhaps based solely on their race, is something that's alarming, and is definitely more work needs to be done to educate physicians and healthcare providers and researchers, and really figure out what is the reason that is causing this barrier for accessing clinical trial care. This also impacts care moving forward, and mortality and morbidity rates in patients, not just in cancer, but in wide range of disorders, including rare diseases, which is what Global Genes focuses on. So the purpose of this slide was to highlight in your mind how pervasive it is that health inequity that doesn't take into account cultural sensitivity, how it can have widespread ramifications in a number of disease areas. I'm sure many of you are very familiar with the graphic on the left. This is the famous Dahlgren and Whitehead's model of determinants of population health. And I put this here just to highlight that if you see in this graphic, general socioeconomic, cultural, and environmental conditions are sort of all encompassing. They not only are a huge driver in population health, but also an individual accessing healthcare resources. So one cannot divorce socioeconomic cultural impacts from an individual who is right here at the heart of things, and their lifestyle choices that then impacts their healthcare. And so the goal of effective health education programs as we're designing them, they have to be multifaceted. And here's a neat little Venn diagram that shows the content of our programs has to be patient-centered. It has to be respectful of health literacy of the population that we're targeting, and not be so full of jargon or difficult to understand words that have no meaning for a patient who just wants to understand what is the disease that they are dealing with. So cultural targeting, as I mentioned previously, cultural competence, which is making sure that healthcare staff in one's organization are aware of the cultural biases that they might have and the barriers that certain underserved populations may face when accessing care. And the underserved needs of certain populations, they might be populations that are underserved due to racial differences, due to socioeconomic differences, their immigration status, educational levels, all of those. And so where all of those intersect is what would make a highly effective health education program. And as you can see, cultural competence is one of the key drivers of that. So what are the results of having a culturally competent program? There have been widespread studies, and I won't dwell on this too much, but studies have shown that improved patient outcomes are a definite consequence of creating culturally competent resources for patients. So here are a couple of examples that I put here. After a medical center introduced a bilingual Russian internist to help resolve language barriers, Russian-speaking patients with diabetes experienced significant reduction in their blood pressure and cholesterol, because not only is the doctor, the physician, the nurses, the healthcare people, not only do they speak the language that you're familiar with, but they understand your culture and where you come from and your belief systems. And I also just wanted to point out, language, as I say, is for spoken language, but it can also be a linguistic barrier. It can also be someone who cannot speak, and we need to be considerate of having sign language interpreters that are easily available that can do American Sign Language. And so that's a nuance of language that I just wanted to highlight here. In another study, an inpatient psychiatric unit that incorporated Spanish language proverbs into their therapy session found increased participation and improved motivation and greater willingness to explore emotional topics among their Spanish-speaking patients. So once again, not just having someone who's learned Spanish, but being able to incorporate things that people use in their daily lives, like proverbs and idioms that might be specific to that population. That makes, in this case, therapy, but it can be applied to other healthcare situations. That makes that content that much more meaningful to the patient that one is speaking to. Increased patient safety is a widespread consequence of culturally competent materials and training. This is I'm highlighting this in the setting of a hospital. So there have been numerous studies and meta-analyses that show that in the absence of culturally competent care, preventable mistakes can happen and adverse events can happen. And that can be due to lack of being able to communicate clearly with the patient because of linguistic barriers, unable to explain the medication levels and the adherence protocol to patients because one is not sensitive to the education level of the patient that one is talking to. And there are many, many examples of how patient safety can be impacted if one is not clearly communicating to patients in a culturally sensitive manner. And of course, increased efficacy and adherence to treatment. So like I mentioned before, if we're not able to clearly communicate to our patients or our patient groups and caregivers, if we're not clearly able to communicate how a medication should be taken, why it's being taken, what is the importance of screening for common or rare health conditions, then it's more than likely that patients will not adhere to their treatment protocols. So a PLOS One review found that Black men rated providers' behaviors and attitudes more positively after the clinic gave its providers cultural competence training. So clearly the outcome was a general feeling of a better healthcare in patients that access this information through this clinic. In addition to raising patient satisfaction, it also increases the likelihood that the patient will follow the medical advice because they understand the importance and they understand culturally, if it's explained to them, they understand culturally why it's important for them to follow this medical advice. Reduce care disparities. As I had mentioned earlier, one of the barriers that among the many, many barriers that people can face is Accessibility, so ensuring that language and culture and race and other factors, they don't become barriers in patients receiving quality care. There have been recent studies that have shown that depending on one's racial background and one's racial makeup, the amount of time it takes to see a healthcare provider is significantly higher for Black, African American, and Hispanic patients compared to Caucasians. The amount of time it takes for patients to see, not just see their internist, but to see a specialist takes longer. And that might be because there might be medical gaslighting, like we heard earlier, where symptoms are not taken seriously, or they're not taken seriously or understood because there's a linguistic barrier. So it all kind of ties in together in terms of language and accessibility. And of course, decreased financial costs for patients and healthcare providers. So if we make the healthcare more accessible and we make it such that it is targeted for people that we are trying to care for, the likelihood is that our patients will adhere to the directive of the medical doctors. They will take their medications when they need to. They will have health screenings. They will take better care of themselves. And that'll ultimately lead to a reduced financial cost for patients because it will not lead to more and more problems accumulating. And also for healthcare providers, if we have culturally competent training for all healthcare providers, it reduces miscommunication, it reduces misdiagnoses, it reduces errors that can happen in medical care that can also add to the economic burden of the disease and ultimately affect the healthcare provider's office as well. I just wanted to touch upon the barriers to healthcare very quickly. I already spoke about linguistic differences. According to the 2020 US Census, almost 67 million people speak a language other than English at home. And so that's a large chunk of people that might not feel comfortable accessing all healthcare information in English. And so language can be a critical barrier in treatment and preventative care. Socioeconomic status, if one has limited or no health insurance, it can be the costs of treatment and the costs of diagnosis can be prohibitive. And so being familiar with that and sensitive to the socioeconomic status of the community one is serving is important. I touched upon immigration status earlier, but Latinx immigrants and mixed immigration status families face many more health inequities and barriers, not just language, including prejudice, discrimination based on their immigration status, and then fear of deportation, which is very real for a lot of people, and it impacts how they interact with their healthcare team, if they interact at all, and if they want to just stay under the radar, as it were. Sexual orientation studies have shown that women in same-sex relationships found to have significantly less health insurance coverage. They were less likely to have preventative care, and they were more likely to report unmet medical needs. And so that is an important chunk of the population that we need to be culturally sensitive to and understand what their unique barriers are. And there have been tons and tons of data on how race and ethnicity impacts healthcare and disparities in health access, and as well as health outcomes, so mortality, morbidity, amount of time to diagnosis between white Americans and people of color. And I've also just left links here for you all to access at your time, but these are either scientific publications or reputable websites that we can use as good resources if we wanted to understand a little bit more about these additional barriers. How can we improve cultural competence? So of course, that's the million-dollar question. Some of the ways I've listed here, and this is certainly not an exhaustive list, but build teams of healthcare professionals that reflect the diversity of the patient populations that we're serving. So if a patient sees that their doctor, their geneticist, their counselor, they look like them, or they understand their language and their culture, they're more likely to listen to what one is saying and to understand the information that one is providing. And so building teams really that are diverse, and not just racially diverse, but diverse in all of these points that I've mentioned here. Increasing provider training to respond with empathy to the unique cultural needs of patients. So just because a patient is deemed to not speak your language or not have the same education level as you, that a lack of empathy when responding to care for these patients is something that is really something we need to educate physicians on. I've talked about language accessibility, reducing these linguistic barriers, be it training more staff in the various languages that are spoken, hiring staff from those cultures, having a sign language interpreter available, things like that. Recognizing that individuals are unique and one cannot predict their behavior and attitudes simply based on their cultural backgrounds. And that, what I'm trying to say here is that we cannot judge a person just by looking at them and their culture. We cannot predict that this is how they will, their behavior will play out just because they come from a certain background. Everyone is unique. And so respecting the fact that an individual's choice might not be similar to their cultural background. Respecting a patient's choice based on their culture or religion. We have to be respectful of when a patient denies care as well. It's their right. But I think understanding the reason they deny care might be an important step to understand how we can prevent that barrier. So what I mean by that is if a patient comes in where their religious or cultural beliefs prevents them from a certain treatment, say a Jehovah's Witness patient who doesn't want to have a blood transfusion, it is imperative that doctors don't try to railroad them into having treatment that goes against their cultural beliefs, but work with them to see what is preventing them to have care. And then at the end of the day, if they do not want to have care, that's completely their decision. Improve patient health literacy by developing culturally appropriate educational material. And this is also imperative because a lot of the material that is either online or in textbooks is not diverse at all. It doesn't show racially distinct ethnic groups, people with different disabilities. If one doesn't see that in the education material that one is accessing, the likelihood of really paying attention to that and listening to that and educating oneself with that material goes down tremendously. I won't spend too much time going down this list, but here's another list of ways that healthcare facilities and companies can increase cultural competency. The last point I think needs to be highlighted, that an organizational cultural shift is what's needed. And so that one focuses on the person and not the disease or the ethnicity that the person comes from. I wanted to provide some concrete resources for everyone where they can access some cultural information in healthcare. So at your leisure, if you'd like to check out any of these resources, I think all of them are excellent ways to increase proficiency in cultural, developing culturally competent educational material. And why, and these resources also talk about why it's important to even bother developing culturally and linguistically competent material. Because I represent Global Genes, which is a rare disease patient advocacy organization, I did want to touch upon very quickly health equity and rare disease. So patients with rare disease, particularly those of color, have additional barriers on top of all the other barriers that we talked about. There's a significant delay in a timely diagnosis, and it is significantly longer than people of other races. There's reduced access to genetic testing, and that comes hand in hand with reduced availability of culturally competent genetic education resources. And as we saw earlier, patients that from the metastatic cancer point of view translates to rare disease as well. They're less likely to be offered and to enroll in clinical trials. And of course, this is by no means all the barriers that rare disease patients face, but just to give you a flavor of additional barriers that these patients face. And so the ways to address these is to create culturally appropriate educational material, which is one of the initiatives that Global Genes is doing currently, making culturally appropriate genetic education and family history material available for Black and Hispanic communities so they can understand the importance of it. Efforts to increase trust in medical professionals based on history and things we've seen in the past. There is a lack of trust in medical professionals. And so accessing healthcare through people that might be community leaders or patient leaders that patients trust is important. Education of healthcare providers, like I've said all throughout, increased access to virtual appointments, which can help people who are of a lower socioeconomic background that can't afford to go get into a taxi and go to the hospital to meet their appointments. Increased opportunity and access to enroll in clinical trials and even being talked to about trials that are available. Greater funding, of course, for research and treatment of rare disease that predominantly affect people of color. So specific rare diseases like sarcoidosis or sickle cell disease, which might be predominantly affecting people of color. More funding for those kind of diseases needs to be allocated. And then creation and support of centers of excellence that are exclusively or not exclusively, but targeted towards the care of underserved populations that are living with rare disease would be a key way to reduce this barrier to care that a lot of patients of color with rare disease face. So finally, I just wanted to finally end with saying that a person should always receive quality healthcare, regardless of where they come from, what they look like, how they identify, any of those factors. And a lot of work needs to be done to identify cultural barriers and then to address those barriers so that there's equitable inclusion of people from diverse backgrounds in accessing care and treatment, so we can reduce the morbidity and mortality of a large number of diseases, particularly rare diseases. And I will end with that.
So I just wanted to thank you, Dr. Mitkus, for that honestly amazing, just like chef's kiss presentation. It was beautiful. I think we can all appreciate the amount of effort that you put into not just defining what culture and cultural competence is, but really, you know, how to act on them. So I really appreciate the amount of effort you put into those slides. So thank you. So at this point in time, we are going to take a 15-minute break. And when we resume, we will jump into our panel discussion. So please take this time to stretch, take a bathroom break, grab some water, and we will see you all soon. Okay, so welcome back, everyone. I hope you've all been able to make it back to your seats. So I'd like to again welcome back Dr. Mitkus and also introduce our two additional panel speakers for this afternoon, which includes Luisa Leal, who is the founder of the Akari Foundation, as well as my personal colleague, Bethany Zettler, who is a senior genetic counselor and project manager for Genomes to People. Would any of you like to give another statement to introduce yourselves before we get started? Okay, so Dr. Mitkus, I just have a lot of questions in my mind regarding your presentation that I think would be a great place to start in this panel discussion. One of the challenges that you identified that we face in providing equitable care is implicit or unconscious bias. And also some of the ways, you know, that some of the steps we can take to either individually or even as an institution kind of overcome those and improve cultural and competence and humility. I think something that we often encounter in thinking about implicit bias is people often want to deny that they have any biases. And, you know, a statement I think I've heard a lot in some of the heated sort of discussions that have been going on the last few years, for example, is a statement like, I don't see color. How do you respond to a statement like that?
That's a great question, Cheyenne. And please, please call me Shruti, Dr.
Oh, I actually
Mitkus.
can't hear your audio.
Oh,
Is that just me? Oh, sorry.
can everyone hear
That
me?
was me. I
Okay,
apologize.
okay, no worries. I was just gonna say, well, I was first saying that please just call me Shruti, Dr. Mitkus, so formal. That's a great question. So I think the number one thing is to first recognize that not all of us, regardless of where we come from and what our backgrounds are, none of us are perfect, right? We always have something to learn, and to not even acknowledge that there might be some biases that I might have, despite how, open and how I think I perceive myself as not having a bias. So I think if someone says, I don't see color, or I don't see race, or whatever else they don't see, I think that's a moment to just stop and say, ask more questions, like, what do you mean by that? Because they might interpret that as something completely different, that I don't see race, versus someone else. And so I think the way I would approach it is turn it back and ask them to clarify, what do you mean by that? There's nothing wrong with seeing race. We're different, I'm a different race than you, and there's nothing wrong with seeing race. It's when we then start to associate certain beliefs, or assume a person from a certain race will behave a certain way, or their understanding of a topic is somehow diminished because they're from a race. That's the challenge there. And so the short way that I would deal with it is really ask the person to expand on what they mean by, I don't see race. And then and the broad context of that is, everyone can benefit from cultural training, regardless of how good one thinks one is in their implicit or explicit biases that they might have. You're still on mute, Sheyenne.
My apologies. I'll get the hang of this. Thank you. Yeah, no, Shruti, I think you're definitely right. I think, right, one of the biggest ways to combat implicit bias, right, is being able to talk about it and creating those opportunities to explore, why we feel that way, and normalizing, right, these conversations about the fact that we all have biases, and what we can do to resolve them. Another challenge you also I think pointed out a few times in your presentation had to do with language as a barrier. And so I actually wanted to ask you, Luisa, because I know a lot of your work is providing resources in other languages, particularly in Spanish. I was hoping you could give us more context as to how translation might be more difficult than people think, and what is it that people might not quite understand about the complexity behind more than just, translating something into Spanish.
Sure. What you were just mentioning, Dr. Shruti, about you don't see race, you don't see color. Oh, well, I'm sorry, someone else. But I can think of that, like, it doesn't cross to my mind how not able to see that, because I'm Hispanic and I've been through all that stuff, it's hard for me not to see there's more than just certain race, but with your question, Sheyenne, it haven't been easy. When I started the organization 5 years ago, I started focusing in translations, and it was taking me weeks to translate just a little content like this, because it wasn't just copy and paste on Google Translator. It was more than that. It has to have a meaning, because Hispanics, we come from a lot of different cultures and different languages. Even though we all speak Spanish in some way, we have different meanings, So I have to make a translation where it makes sense to a lot of different cultures. So it was very hard for me. Even though we had a conversation with my team, I think it was like a couple of weeks ago, we were doing this translation, and it was just one little word, one little sentence. The meaning of fill out something, right? A paper or something. And we have different, I have someone from Argentina, Colombia, the south of Mexico, and I'm from the north of Mexico. And we were trying to get, translate one little word, and we all came with 4 different meanings. And it was like, this means this in our country, this means in, so, it's more than just a translation, especially when it's something medical. You have to be extra careful on how do we translate. I'm lucky enough that I have someone with a medical background in translations in our team, because we couldn't just, I wouldn't feel comfortable of being just sharing information. I have seen where families just copy and paste, and I asked them, because I noticed this person in particular, they're posting all this, and I was like, where are you getting all that information? Because we don't even have access to that information. She's like, oh, I'm just copy and paste. I was like, no wonder. So when I created a nonprofit, like I said, it was for translations, and I realized really soon that it was more than just translating. It was more about the culture. I love every single thing that you mentioned, Dr. Shruti, because you pretty much mention everything that I have to say here. I'm done, bye. But yeah, no, you pretty much, put the nail on the coffin.
Yeah. Can I just piggyback on that real quick, what you said, Luisa? And that reminded me of, relying on Google Translate to make your Spanish language content. Big mistake, right? So the cultural nuance and what you said about how the Spanish spoken in Spain is different from the Spanish spoken in Mexico, right? Mm-hmm. And it reminded me also of a story that I read, which is very unfortunate, but I thought I'd highlight it here, is that a young man presented to the paramedics with symptoms of feeling very unwell, and he passed out. But right before he passed out, this was in Miami, so he only spoke Spanish. And right before he passed out, he said some words that had the word intoxicado in them, and the paramedic, right?
Paramedic. I where you're going for.
Yeah. So the paramedic, who spoke broken Spanish, assumed that he was intoxicated and was probably ODing, and treated him accordingly. Turns out the young man had a brain hemorrhage that they didn't know about at the time, which negatively affected his health down the road tremendously. But that word intoxicado, what he meant was, which can also have the meaning of feeling sick to your stomach and feeling nauseated, which is one of the symptoms of a brain bleed. And so and he ended up, paralyzed from that brain bleed, and it led to a $71 million lawsuit with the hospital. But that being aside, that just tells you nuances where we sometimes think we know that a word because it sounds a little bit like the same word in English, and what a huge impact that can have on a person's health and downstream. I just wanted to highlight that it's not just about hiring a few people that have a little bit of training in Spanish, say. It's about that holistic approach of culture and the nuance of when I say this, it sort of means that. So I just wanted to throw that out there.
Yes. Yeah. And like you said, I got from the beginning, like a lot of people told me, why don't you just join another organization to translate, one of those big organizations that are already out there. And I told them since the beginning, this is just more than a translation. It's cultural, and then on top of that, add the immigration part and the shock of transition from one country to another, that we're afraid of. It's a lot. It's bigger than that. I'm sorry. I'm just going through a different direction, but yeah, it's so much. much than that.
Yeah, it really highlights the importance of services that we take for granted, such as interpreter services. I know in my short time as a genetic counselor, it can be really difficult to access some of those services. And, it leads me to think about, generally in what other ways, I know a big part of the summit is also focused on digital health. Which is something, I think it's a future we were always, going towards, but COVID certainly kind of sped up that process. So Bethany, I wanted to direct this question to you just to give you an opportunity to talk as well. But what other ways do you think, going towards this future of digital health might, exacerbate or improve some of the health equity and access?
Yeah, that's a great question. Thank you, Sheyenne. I can just speak from my small corner of the world in genetics practice and in genetics research. We have pivoted towards telemedicine since the COVID pandemic and see almost all of our patients virtually now, which, for some people is great. For people with maybe mobility issues, it's really nice for them to not have to come into the office. It can be cost saving for some people. But at the same time, it's making a huge assumption that patients have access to, high-speed internet and a device to actually contact, the doctor and the genetic counselor. So I think in some ways we're just missing a huge swath of the population, especially the rural population, who could benefit from, shorter travel distances, but might not have that infrastructure of the high-speed internet. So it's definitely a challenge in clinical practice. And then in research, we are trying to reach more community-based healthcare clinics, and we're really trying to expand access as much as possible by having things available like texting communication versus email or phone calls, having apps on the smartphone to fill out surveys, really just creating as many resources as possible, videos you could watch on a smartphone. And for some clinics, like in Boston, they're like, this is awesome, our patients are gonna love this. And then from one of our clinics in Birmingham, Alabama, they're like, no one is gonna be able to use this. So it's definitely, we're just trying to create as many options as possible to include as many people as possible. But I do think digital health is, kind of a double-edged sword in that way, that it is really beneficial to some people and, really leaving other people behind, unfortunately.
Yeah, one of the options I know we've come across in our study that we're working on together is I think a clinician had recommended texting, and the idea of like texting a patient is something that never would have occurred to me before. But when I think about my personal life, I don't always answer calls, especially ones I don't know, and I'm definitely more likely to at least read the text, even if maybe I don't respond to it, right? So certainly, thank you. Shruti or Luisa, do you have anything else you'd like to expand on in regards to digital health? And
in our case, we noticed that we've been trying to reach to the families. And my background is in marketing, so I'm like very about push social media, and then the family start reaching out through Facebook and Instagram, but then TikTok happened, so people are reaching out through TikTok now. But we were having a hard time to people to reach out to us. It was just through like the message under the post and stuff like that. So I decided to get an additional phone and just use it for the WhatsApp messages. And that's how we got, a lot of the families to reach out to us. What we notice is that the Hispanic population use a lot WhatsApp, and we noticed that after each webinar that we had, that's when we start getting all these messages, So at the beginning, I was answering every single message, but it was crazy because people do not understand that people have a personal life as well. And I have kids. So, they were texting at any time, any day. And then like, hello. Like, it's midnight here, So I just, basically put a little automatic message. We will reach out to you Monday through Friday, 9 to 6. And even though we work after hours, but and then a reply with a link to a survey. So whoever answered the survey, that's the people that we reach out. Because like I said before, we were back and forth on messages, and we couldn't get into nothing in a specific. So now that they fill up the form and we ask, what do you guys, basically, what is your request? What do you need? And that is a lot easier for us. And then Caro, which is our assistant, she goes through all the messages and said, you know, this, I can handle this, you can handle that. So we send it to different people in the organization. Well, it's only 4 of us, but and then Maria, our director of social services, she mostly handle all of them, you know. So if they need help with information on clinical trials, or you know, they need a wheelchair and we don't have the funds for that, but there's another organization who does, you know, we try to accommodate them like that. So yeah, I mean, WhatsApp has been really, really helpful for us.
I just wanted to add to that, to what Bethany and Luisa said, for what they call these care deserts, right? Where, you know, deep rural places, or places, you know, because of the financial burden of it, not having internet service or a smartphone or whatever. These care deserts that are now we've identified, I think the way to reach them is really through grassroots community organizations, people going door to door with flyers and things like that. But then that also brings up the fact of trust in the community services and the community organizations. These kind of strategies will work efficiently and will be helpful if the people that you're serving trust the community centers and trust that you're, you know, people knocking on their doors are not just, you know, random people that they ignore. So I think digital health, of course, maybe for the majority of people will work very well, including telehealth and all that entails, WhatsApp and things like that. But I don't think we can trivialize the impact and the need for grassroots, you know, community health workers going door to door and educating people.
Yeah, it's one thing to you know, create resources. It's another thinking about how do our participants or patients actually access them. So I'd love to get some more thoughts on thinking about, you know, in what ways might individuals access some of these resources, and what might be the best way to get it to them.
I can start the discussion off a little bit based on my work with Global Genes. We have an initiative that we're working on with Rare Disease Diversity Coalition, where we're creating print and social content to educate people, particularly people of color, on the importance of talking to your family history. Why should you know that, and how will that impact your health? And so we have found it to be challenging for Black people, for Hispanic people, to really access that care, that information. Let me rephrase it. We found it challenging to find places where they are trusted resources for those communities. And after having talked to a bunch of people and understanding the problem, it seems that community clinics that are run in those communities, as well as faith-based organizations, so churches and, you know, Catholic Archdiocese or, you know, the Baptist churches in those areas are trusted sources. And so if we can distribute our educational material or our campaigns through those kind of resources where people come, they trust, you know, my pastor is telling me this, that it's important for me to talk to my family about this and that. I think those are good ways to really have people access care through these trusted places. And I just wanted to also just touch upon really quickly that Global Genes has a, in my mind, very unique and service called the Rare Concierge Service, and you can access that through Global Genes' website, where an individual who has access to technology, unfortunately, can fill out a form and get their specific question answered about rare disease, genetics, clinical trials, treatments, or just, can you connect me with someone else in the world who has my disease, right? Especially for some of these ultra rare diseases, or just someone to offer emotional support. You can fill out this form and put in your question, or not even a question, just say what you're feeling at the moment, and a patient services guide will answer that question and link you to other foundations and organizations, or answer your questions about clinical trials or genetic testing and things like that. So I just wanted to put it out there that this is a great resource, particularly for the rare disease community, to get their specific questions answered. And I'm not quite aware of other large advocacy organizations that also do that. So,
And that's exactly what we do, but 100% in Spanish.
So-
Because we have a psychologist on staff, and then we have our I forgot our ambassador program for, it's this basically what we call a veteran parent who they've been through this deal with the disease for more than 5-6 years, and we try to connect them with newly diagnosed families, so that give them that support that they need, and if they need extra help, we have the psychologist. And then like I said earlier, they fill out the form and we contact them. The director of family services contact them and ask exactly what they need. They go through what they need and everything. So it's been helping a lot. I think we've been able to connect more with the families that way, and it help us to have a more structure than we had before, about a little paper here, a little paper there, an email here, an email there, tag you here, tag you there. It was just all over. Yeah, so now it's been helping us. I think we have a better system now, and we're still working in a more complex system, but it will be a lot easier at the end. So yeah, we're waiting on new software there.
Thank you for informing us of those resources. I definitely have to check them out myself. I think they'd be a great addition to definitely some of the work Bethany and I have been doing as well. But I know we also mentioned, I believe there's some mention of like trusted leaders that some of our patients or participants might look to. Shruti, I believe you said like church leaders for those who might, follow a faith of some sort. And I think a lot of how we learn about some of these resources and, who do our patients or participants trust is through, some of the work that Bethany and I are trying to do, such as stakeholder engagement in our Baby Seat project. And so Bethany, you probably could have already could tell I was getting ready to pivot to you, but I'd love to hear more about your experience and how it's been to convene a stakeholder board and maybe some of the lessons learned and the challenges faced.
Yeah, thank you. And you could probably speak to this just as well as I can. I know you've done a ton of this work, but it has been really great getting our board together. So we actually don't have any faith-based leaders on our board, but we do have, we're recruiting infants from this study. And so we do have a couple of midwives who are familiar with delivering babies within the community. We have a couple of former research participants who can use their experience to inform our practices. A couple of people involved in like early childhood education. So really nice perspectives that have been super helpful. And Sheyenne, you mentioned a couple of ways that this board has helped to shape our study. I think one key that has helped with our relative success so far is that we engaged with our stakeholders super early. So actually, as soon as we were writing the NIH grant submission, so actually asking the government for funding, in that initial submission, we actually got letters from about 12 different community stakeholders. So we got their buy-in, and they were willing to actually write a letter saying that they supported this work and would be involved. So that was really awesome. And I think this was actually the third time we had asked for funding. So I think that engagement actually really helped get our grant over the edge and actually get us money to do it, which is awesome. And that was about 1.5 years before we even started planning the study. So I'm really hopeful that the NIH will continue to recognize that that is a really important part of study design, and that will be a continued part of the policy and funding. And since then, it really has been a partnership. A lot of our actual research investigators have been in this field for 30, 40 years and are pretty set in their ways. And so I think that's where, kind of intermediaries like Sheyenne and I are really helpful to listen to the stakeholder board and, translate those ideas a little bit into actual research recommendations. And one specific study design recommendation actually took a ton of communication, a ton of literature review for me and Sheyenne, a ton of discussions with the team, special meetings with the investigators, but eventually we were able to implement the stakeholder recommendation in that case. So I think it is a lot of communication. It's not something that is, it hasn't really been an expectation in the past, but I really think going forward, I'm really hopeful that research does include that more and more.
Thank you, Bethany. And just with these last 2 minutes we have, and of course, any of the three of you comment on this, but thinking about, we were talking about health disparities, and of course, with that comes inclusion. But I also think about the opposite end, where in trying to include more diverse patients participants, sometimes the darker side of trying to do that leads more to targeting rather than, for our own personal gain rather than for their own. So what is some of the ways that we can try to avoid tokenizing some of these underrepresented minorities? I'd love any thoughts on that.
Sure, that's an excellent point you bring up, Sheyenne. Certainly one doesn't want to be, feel like, as a community being targeted. I think it all really boils down to, one, again, how much trust and reputation you have in the community in terms of your intentions. Are you just going in there and seeing, what you can get from the initiative that you're doing? So I think building trust in the community is important. And then how you gear your material and how you message that is super important, I think. Because if it's, there's a nuance between the way you say it and does it make someone feel targeted, or is it truly because you think this community is underserved, it can really value from the initiatives and campaigns and education materials that you're creating, or whatever else that'll impact their healthcare. And then, like Bethany mentioned, getting buy-ins from different stakeholders that have possibly already established connections within these communities. And so again, building that trust that we're not doing this for our own benefit, but a benefit that we think will have a larger community impact. Yeah.
Okay, so I know we're a bit over time, so that's probably all we have for this session. But I wanted to thank all of our panel speakers for all the work that you do, of course, and also for taking the time to discuss this really important topic on health equity and access and with our audience. So thank you.